Hello, everybody. Thank you very much for joining our first REMPAN webinar. I'm Carr with the World Health Organization Radiation Program in Geneva, Switzerland. And I'm happy to introduce my colleagues here. And first of all, Dr. Emily Van Deventer, who will give us a few words of opening and welcome for this webinar.
Good afternoon, ladies and gentlemen, colleagues. We are very happy to welcome you today to this first topical webinar in what we hope will become a regular webinar series, provided for and by the experts of the WHO REMPAN network. The choice of the topics for these webinars will be driven by the interest of the REMPAN specialist community and most likely will include various scenarios of radiological and nuclear emergencies, case reports, and special medical topics. Today's topic is public health impact of a nuclear detonation. It has been 45 years since biological weapons were banned, and 25 years since the ban of chemical weapons. And finally, last July was the turn of nuclear weapons. And indeed, in 2017, more than 70 years after the world witnessed the devastating power of the nuclear bomb, a global UN treaty was approved to prohibit nuclear weapons. This being the first legally binding international agreement to comprehensively prohibit nuclear weapons with the goal of leading towards their total elimination. The treaty was endorsed by 122 countries at the United Nations headquarters in New York. It was a long road, but a successful one, thanks to the efforts of civil society, and in particular, the International Campaign to Abolish Nuclear Weapons, ICAN. And you will, of course, have heard of ICAN, which was awarded the Nobel Peace Prize in 2017 for, and I quote, its work to draw attention to the catastrophic humanitarian consequences of any use of nuclear weapons and for its groundbreaking efforts to achieve a treaty-based prohibition of such weapons. WHO's overarching mandate is to protect human health. And in doing so, we worked with our member states' health authorities to develop standards, to develop policies, programs that would ensure that people have access in our work to the safe environment that includes clean water, air, food, and health care. Today, we are happy to welcome 4 speakers in this webinar. And I will mention their names, but they will maybe introduce themselves a little further on. Dr. Kazunori Kodama from Hiroshima, Japan. Dr. Bob Whitcomb from the Center for Disease Control in the USA. Dr. Rajesh Sreedharan from here in WHO in Geneva. And my colleague, Dr. Carr in the Department of Public Health, Environmental and Social Determinants of Health. So I will pass back to you, Janet, for continuing this webinar.
Thank you, Emily. Before we start, I would like to just make a small announcement explaining that at the end of the 4 presentations, we will have a questions and answers session, and we'll take as many questions as we can in terms of time limit. We should normally fit into 1 hour, but we can use maybe 15 more minutes because this facility will be used by another event afterwards. To ask your question, I will ask you to go to the little chat box at the bottom right corner of the WebEx window. You can see the little session called chat, so you can type your questions there, and we will select several questions from the chat window. And the question could be actually addressed to all or specifically to me, Janet Carr. I hope that's clear. Another request is to all of you, kindly mute your microphones. We also have this option to mute it centrally, but just in case, if something goes wrong, make sure that we don't hear crying babies playing music and barking dogs, which some of you may have around you. All right, without further ado, I'm happy to introduce our first speaker, Dr. Kazunori Kodama, whom we have known for I personally know him for more than 10 years, and he's been with WHO for 3 decades as a member of WHO Collaborating Center Radiation Effects Research Foundation in Hiroshima, Japan. Kaz, over to you, please.
Thank you. I hope you all can hear me. I'm Kaz Kodama from Radiation Effects Research Foundation, and I'm very happy to be one of the participants of this webinar conference. I have been working, studying on health effects for more than 30 years at Radiation Effects Research Foundation, and I'm happy to make some presentation on what we have learned based on the studies of atomic bomb survivors.
You can start sharing.
Can I just go ahead and start?
Yeah.
Okay. Now I'm going to give a talk on studies on radiation health effects in atomic bomb survivors, and I'm going to focus more on historic perspectives and 7 decades of follow-up. Okay, this is the outline of my presentation today. I'm going to start from talking about atomic bombings and human casualties, and then touch on emergency medical care provided by medical professionals immediately after the bombing, and then describe acute health effects of atomic bomb radiation, and move on to next very important issue, which is the late health effect, and finally touch on prevention of radiation health effects. Okay, as you all know, first atomic bomb was dropped to Hiroshima on August 6 of 1945, and second one was dropped 3 days later on August 9th of 1945. These are, mammoth atomic cloud. Left side is from Hiroshima, and the right side is Nagasaki. And this is, case of Hiroshima. The Hiroshima city was totally destroyed like this. And this slide illustrates estimates of early deaths and injuries. Again, this is the case in Hiroshima. Any point available? Can you?
Your mouth should be used.
Okay. Here there is a number of number of dead within a year after the bombing. Number here says about 120,000, but this is still not quite right, because we have no idea exact numbers about numbers of deaths. Smallest number I got is 90,000, and largest one is 160,000, so somewhere between. And also there are many seriously injured. Now, but emergency medical care provided at the time of the bombing. Okay, since many hospitals are destroyed by the bombing, elementary school like this was used as a relief station and provided medical care for victims as an outpatient or as as inpatient as well. And this is the story. Excuse me. Written down by the physician who took care of victims, and he clearly described the situation of the relief station on August 6 of 1945. I just read through this. There was a surge of survivors needing emergency care. By evening, more than 1,000 survivors came to the relief station, and classrooms, corridors, and even playfields were flooded with survivors. There were a variety of injured people whose shirts were torn to shreds. Some were half naked and heavily burned. Some had epidermal detachment with pieces of glass stuck in their bodies, and some suffered laceration or other injuries. Injured people were lined up waiting for treatment. I felt helpless and sad watching some of them die while waiting for their turns. Because treatment was limited to injection, bandage, mercurochrome, ointment, zinc oil, and we are severely short-handed. I could not give them adequate treatment. Throughout the night, I heard voices asking for water, complaining about pain, and groaning in pain. No matter how desperately I wanted to help them, I could not give necessary treatment due to a shortage of manpower. After treating patients all through the night without a wink of sleep, what I saw was dead bodies lying everywhere. As the day go by, the number of deaths continued to increase. I think this, is a typical story what people experienced at the time of the bombing. Now, one more thing I want to emphasize is, medical professionals like doctors, nurses, and others themselves are victims and exposed to radiation as well. This monument we have, in Hiroshima, named Praying Hands, was elected on August 4th of 1960 by members of the Hiroshima City Medical Association and many others to console the souls of doctors, nurses, and other health professionals who died on duty or as a result of radiation exposure from the atomic bomb. They devoted themselves to relief activities even while they themselves suffered from the atomic bombing. I think this is something we should keep in mind. Okay, with regard to acute health effects of atomic bomb radiation, these acute radiation syndromes appeared over the period of several weeks. Epilation came first, and subcutaneous bleeding, and followed by oral pharyngitis. This is a famous picture showing subcutaneous hemorrhage appearing on patient's face. Epilation, the first symptoms in this case, and then gingival hemorrhage, purpura, and fever, oral pharyngitis and hemorrhagic tendency appeared, and finally he died on the 3rd of September 1945, within a month from the bombing. Okay, late health effects. Okay, within two years from the bombing, Atomic Bomb Casualty Commission was established, and in 1975, this Atomic Bomb Casualty Commission was reorganized into current Radiation Effects Research Foundation. ABCC continued to work studying on health effects for 28 years, and Radiation Effects Research Foundation is now studying health effects for more than 42 years, and altogether we are doing studies for more than 70 years. There are three major populations we are working on, which include population of atomic bomb survivors. This is the largest population of 120,000. It is called as lifespan study. And also we have unique exposed population, which we call in utero exposed, a group of people who are exposed as a fetus. And then we have third population, which is offspring of atomic bomb survivors, 77,000. Now, on these three populations, we have mortality follow-up, cancer incidence follow-up, and clinical follow-up. And clinical follow-up is being conducted on the subset of population. Now, the cohort study of the Japanese survivors of the atomic bombings of Hiroshima and Nagasaki is broadly considered one of the most reliable sources of information on radiation health effects because of the size and nature of the population investigated and the scale of the data available. For this reason, the study has become fundamental to the risk assessment of radiation exposure, and study results have been utilized by the international organizations such as United Nations Scientific Committee on the Effect of Atomic Radiation on Scare, International Commission on Radiological Protection, ICRP, or International Atomic Energy Agency, IAEA, and WHO, and other authorities. Okay, I'm going to talk only about cancer today, and this is the site-specific cancer risks based on life observation in the lifespan study. Now, cancers confirmed to be increased with radiation exposure include leukemia, such as acute myeloid leukemia, chronic myeloid leukemia, and acute lymphoblastic leukemias, and other cancers, like cancers of oral cavity, esophagus, stomach, colon, liver, thyroid, breast, ovary, lung, bladder, skin, and brain. Now, there are cancers still not confirmed to be associated with radiation exposure. These are gallbladder, cancer of gallbladder, pancreas, kidney, rectum, prostate, and uterine cervix. This indicates the risk estimation of each cancer site based on the observation, for almost 50-some years. I'm showing relative risk here. Sex average at age 70 for exposure at age 30, and leukemia risk is about 2 by receiving 1 gram of exposure. And for all solid cancers, relative risk is 1.5. This means 50% increase by receiving 1 gram of exposure. But among cancers, lung cancer and breast cancer and bladder cancer appears to be showing higher risks. Okay, this is the attributable fraction of atomic bomb radiation observed in our study population. For leukemia, about 50% of leukemia cases occurred among survivors estimated to be radiation-induced. But for solid cancer, only like 10% is estimated to be caused by radiation. This is the risk of cancer by age at exposure. As you see here, younger the age of exposure, higher the risk of developing cancer, and this is more prominent among thyroid cancer. Now, this is most updated findings on risk estimation, indicating lowest significant dose range. The lowest dose range for which there are statistically significant risk is 0 to 100 milligray. This means risk, This means we can detect increase of risks statistically around 100 milligray of exposure. Now, other findings on cancer and leukemia risks. Now, cancer risk elevation associated with A-bomb radiation exposure seems to continue for the lifetime. This is very important findings. And leukemia risk elevation also persists. It was once believed leukemia risk disappeared, but that is not the case, and still, risk persists. Myelodysplastic syndrome, MDS risk appears to be increased, and the increase in risk of first primary and second primary cancers seem comparable. And finally, radiation effects on lung cancer risk seems to be stronger among smokers. Okay, finally, I want to touch a bit on prevention of radiation health effects. Now, in 1984, WHO published a report entitled Effects of Nuclear War on Health and Health Services. And this report was revised in 1987. 1987 is an important year for WHO REMPAN because WHO REMPAN was established in that year. Now, there are many important comments in the summary of this report, and I cannot show you everything, but the important one I thought was, in addition to the immediate effects of blast and heat, the radiation and fallout of nuclear explosions have devastating effects in both short and long term. That's what this report stated. And this is a kind of a conclusion. The report says, therefore, the only approach to the treatment of health effects of nuclear warfare is primary prevention. That is the prevention of nuclear war. And ultimately, this means ultimately abolition or elimination of nuclear war. This is very important. And I think we should put more emphasis on primary prevention. That's all I should mention today. Thank you very much for listening.
Thank you, Dr. Kodama. A very insightful and interesting presentation. Before I give the floor to the next speaker, I just want to remind you that there is a chat option in the screen. If you see on the right-hand side of the screen of WebEx, there is a blue color icon. So the second one says chat. Click on it and you will be able to type in the window your questions. Because at the end of the webinar, we will take questions which were sent through chat only. With that, I would like to pass the floor to our next speaker, Dr. Robert Whitcomb, who is joining us from CDC in Atlanta, Georgia, USA. Robert,
Thank you,
are you there? Yes.
Janet, can you hear me?
We can hear you very well. You need to...
I need to get the previous presentation off my screen so I can access mine.
We stop sharing now. No, don't do anything. He will do it. Yeah. And then you will share your screen. Okay.
Ah, there we are.
At the moment, we have some 60 people online and present physically. So
Okay, can you see my screen now?
we can see your screen. You can maybe go full screen in your PowerPoint. Yes, that's right. Go ahead. Thank you.
Okay. Jeanette, thank you very much. I am honored to be here amongst my honorable colleagues in presenting you the public health resources to meet critical components of preparedness, especially for the scenario just spoken of and for future scenarios that we might have to plan for. The previous speaker discussed the devastating impact of a nuclear detonation, and even under such conditions, there's a lot that can be done to begin to prepare for, respond to, and recover from such an unthinkable scenario. Planning and preparation are key for managing the event, but most importantly, it will help us save lives. I will highlight some of those preparedness activities that will help us do that, save lives. During an emergency, a radiation emergency, state, local authorities will need to quickly assess the degree of hazard and issue appropriate protective actions to people in the affected area. For the scenarios discussed today, there are some differences in the impacts that one could expect depending on how and where the device is detonated. If the device is detonated in air, we call that an air burst, such as those discussed earlier at Hiroshima and Nagasaki. We anticipate much larger blast effects and less fallout compared to a ground burst such as an improvised nuclear device scenario. As with any radiation incident, the areas closest to the blast, shown in red, will have the highest radiation levels. As we move away from the blast and as time goes by, we will see decreasing levels of radiation in the orange, yellow, and green depicted in the figures. The higher the radiation levels, the higher the likelihood of acute radiation effects, as was discussed before, and even death. As mentioned, in addition to high exposure to radiation, we will see large numbers of fatalities and injuries near the blast zone, including burns and trauma. Depending on the location, the radiation dose to an individual may be acute and may result in acute radiation syndrome, or chronic, such as the development of cancer later in life, as was discussed in the previous presentation. In addition, there will also be contamination as the radioactive materials travel downwind. We anticipate that the displaced population, both injured and not injured, will suffer from anxiety and mental health issues. Based on our experiences from the Guyana incident in Brazil in the 1980s, as well as Chernobyl and most recently Fukushima, displaced populations are likely to be stigmatized. Similar to other disasters, public health will have a huge role to play in meeting the needs of the impacted community. The list presented here is by no means exhaustive, but just think of these as routine public health activities that will get complicated by the presence of radioactive material in the environment and on property and on people and pets. State and local public health will also be responsible for following activities such as delineated in the Nuclear Radiological Incident Annex. This is the U.S. Specific planning document, which includes population monitoring, health surveillance and epi investigations, distribution of medical resources, and communication of guidance on altered standards of care and scarce resources, also mentioned in the previous presentation. As mentioned, communication is going to be key to help save lives. Public health agencies should be prepared to issue immediate instructions for people to shelter in place, and be aware that shelter in place is counterintuitive to what we would normally do during an explosion, which is flee the scene. Making sure people understand that they are more protected if they shelter in place and wait for instructions rather than venturing out. They need to be prepared to deliver messages about the need for or not for the need and availability of countermeasures. So plan for redundant communication methods, and if your infrastructure is destroyed or severely damaged, how will you get the message out? There are several mitigation interventions that can help reduce people's exposure to radiation. The most important intervention to protect the public after a nuclear detonation is to shelter in place. And you can think of shelter in place like you would for protection during a tornado or other weather event. A sturdier building will provide better protection than, say, a wooden house, or for that matter, being outdoors. Sheltering in place for 24 to 48 hours will also reduce the levels of radiation that people might be exposed to. People can reduce their exposure to harmful radioactive material and thus their radiation dose through decontamination, which is the removal of radioactive material from a person, an object, or a place. Simply taking off the outer layer of clothing can remove up to 90% of that radioactive material. Washing the hair and the skin with mild soap and water will also reduce that even more. This is a mantra that we all use in our response to radiation emergencies. Treating life-threatening injuries should not be delayed because of concern for contamination. Healthcare facilities have radiation professionals in their staff, such as the radiation safety officer, nuclear medicine, radiologic technologists, and medical physicists that can assist with the radiation protection and help answer radiation-related questions. Only a few types of the medical countermeasures that we have available to treat internal contamination. Currently, ones only treat a few specific radionuclides, and a nuclear detonation would result in many other types of radiation. Thus, most are not generally useful in a nuclear detonation and are not recommended. Cytokines, however, listed at the bottom, are recommended and would be useful. There are many components to public health preparedness, and I just want to highlight some of those and present what we at CDC have developed to assist our state and local colleagues in helping their programs in developing them. Population monitoring, community reception centers, public health and medical care for vulnerable populations, medical countermeasures, the treatment of casualties, mass fatalities, and shelters to monitor for radiation and health issues. Risk communication for protective actions is very important. Knowing the complexity of the radiation terms we use, it's helpful to have well-scripted, well-thought-out communication messages beforehand. Worker safety and health, including protective equipment, dosimetry, and radiation control zones are also helpful. And then laboratory testing for environmental samples, critical components to help identify areas contaminated. So CDC has resources to support the state and local public health planning and preparedness. The technical resources we have includes guidance, training, education, and tools, and then financial resources, which are in the form of preparedness grants that CDC offers to our public health emergency preparedness partners. The next few slides will showcase some of those tools and products. One of the tools we have is the Community Reception Center Toolkit. This tool has templates to help users conduct a drill from planning to evaluation, and it includes over 100 different victims cards that can simulate an impacted population, including the needs of special and vulnerable populations. Developed in collaboration with our NACCHO colleagues, this is our National Association of County and City Health Officials in the U.S. The Shelter Exercise Toolkit is designed to help prepare to set up shelters for displaced populations that may be contaminated. And this toolkit also has customizable templates and 2 videos to enhance and add realism to exercises. Conveying information about radiation levels, as I mentioned before, can be difficult, and more so in the middle of emergency when people will be anxious and scared and frightened. We created the Radiation Hazard Scale to put radiation risk into perspective and also provide protective actions in an easy-to-understand color code. As mentioned, there are many misconceptions about radiation, and this tool features persons on the street interviews, expert responses to 7 of the most common myths about radiation, and it also provides communication strategies to debunk these misconceptions. This tool helps explain how environmental measurements can help and can be used to make decisions, and provides an overview of state and local assets that can help. These and many other resources for planning and response are available on CDC's emergency website. Other key issues to consider in your preparedness efforts include deployment and use of medical countermeasures, like we have in our strategic national stockpile, but also including and conducting epi and lab investigations and initiating longitudinal health surveillance. This is the long-term monitoring, as discussed, similar to the lifespan study in Japan. So with that, this is a broad overview that I've given regarding the public health and medical response that we are planning for and preparing for in the U.S. for what we hope will be never seen and never experienced again. So I thank you for your attention, and I know that Jeanette has the slides set. There are many useful website links. One listed here is CDC's emergency website on radiation. There are others listed that include REACT's, the REM website, which is the Radiation Emergency Medical Management website at HHS, which is our parent agency. And so we have a lot of our CDC resources linked to both and those other resources as well. So thank you much for your attention. I appreciate the interest in the presentation, and I do hope it was helpful. Thank you.
Thank you very much, Bob. This was really great, very concise, and very actually packed with information presentation. Thank you. We are really happy and proud to have such a strong professional in our network, and it is really enriching for us to have collaborators like yourself, like a CDC group. With this, I would like to pass the floor now to the next speaker, who will talk about WHO's work in the area of strengthening countries' preparedness to health emergencies. Dr. Sreedharan, the floor is yours.
Great. Thank you. Good afternoon and good morning, good evening. It's my pleasure to speak to all of you, and thank you for inviting me to this important webinar series. So my role here is basically to talk about the international health regulations and the work that we're doing within our department and our WHO Health Emergencies program under the international health regulations. So the presentation that I'll do is to step back just a little bit to talk about what we're doing generally across countries to help them prepare. And so I'll basically have a few slides on the current status, then I'll talk about the international health regulations, and then the specific IHR monitoring and evaluation framework that we're working with countries to implement. Okay? So when we talk about infectious diseases and we're trying to see if we're prepared, we're not just asking about if countries are prepared, but we're also asking if us as agencies, partners, technical agencies, and international donors are also working together to see if we're prepared. If we look between 2011 and 2017, what we've tracked is the big outbreaks. We've had more than 1,000 outbreaks in 168 countries, and that's the numerator from a denominator of 196 member states. And this also includes industrial accidents, especially the big ones that affect multiple countries, like Fukushima in 2011. So the reason why, even though the IHRs came into effect a while back, that we're still trying to see how we can work together to reduce the impact on the whole of society. When we talk about things, especially of known diseases with known outbreak response and known treatment measures, we can see how it impacts the whole of society, not only in making sure the right risk communication messages go out, but also the pressure on the government to react and to do things that may or may not be useful, but they've been asked to react, and also the financial impact, including the impact on travel and trade. So this is just a quick snapshot of a few of the big events, and we talk about the impact on travel and trade, not just when agencies and countries react or are slow to react. We can see the impact that it happens right from Sorry.
What did you do, Raj?
Sorry. So from the millions of dollars to the billions of dollars, especially when there's global spread of disease. What we see now, and the work that we're doing not just within WHO but across with all of the various partners, is basically because there is an unprecedented growth in population. There's a huge, especially in countries like mine, from India, where we've got lots more people moving from villages to cities. So the urbanization is increasing as well, and of course, travel has gotten cheaper, faster, and in some ways more efficient. So the global spread of disease is not just within certain countries. It can easily start from one country and spread it around the world in a matter of hours, if not days. The work that we do specifically within our department and within the departments within our emergencies program, we look at infectious diseases and public health threats. So we're talking about, since 1970 to 2007, we're talking about more than 1,400 new pathogens, 177 of them just since 2007, and 70% of them are of animal origin. So we, with the IHR and with the work that we're doing, we're linking very closely with our partners in OIE and FAO as well to make sure that the advice that we're giving countries in working closely together with agriculture and animal husbandry is something that we're replicating here at WHO as well. Now, after all that, the good news is that we do have an information revolution, a biotech revolution, and of course, I might be biased, but we also have the international health regulation. So I'll focus on what I'm more knowledgeable with, so I'll focus on the IHR. And the strength in the IHR is something that comes out of the fact that 196 states parties to the IHR and states parties of the WHO are all signatories to this. It's legally binding, and it's something that states parties insisted that we have. So WHO is only has the mandate of the IHR. We help states prepare, report, work together, and we coordinate all of this. But it's an initiative, and the work is being done by the states parties, and the timelines and the deadlines set for the IHR are also things that the states parties have imposed on themselves as part of the global, as part of citizens of the world. So the revision that happened in 2005 to this legal mandate was basically the update of the 1969 International Health Regulations, where we originally had the instructions at that point were limited to a few diseases, and it was more from control at borders. So to try and prevent the international spread of disease, it was to try and contain the disease within the country. But since then, we've moved to containment at source. So we're trying to make sure that countries have surveillance and response systems that are sensitive enough to not just detect, have timely detection of public health threat, or maybe not a public health threat, but also a way to respond to it as quickly as possible to contain this within that source and save lives, rather than have it spread through the whole country. So along with that, the old 1969 version had a list of diseases that countries are supposed to report to, and we've transitioned from that to all public health threats, so anything that can impact the public. And also from preset measures to adapted responses. So we're looking for something that's a bit more flexible and something that can adapt to whatever the situation is, even before the pathogen can be identified. So along with that, our Director General has the ability, with the advice of an IHR emergency committee, to come up and say that and declare that something is of a public health emergency of international concern. And this is the decision that the Director General of WHO can make, and can also issue the country with temporary recommendations. Of course, this goes hand in hand with the support that countries and countries all around the world and all our technical partners would give the country as well. So again, to more positive news, we've also been able to move forward to see how we could fill the gaps within global health security. So even though the IHR has been in force for 10 years, so it came into force in 2007, we've noticed that countries have they've built capacity, but they've been slow and not as consistent in developing the core capacities that countries should have had by 2016. So part of what we've done within WHO is to try and ease some of the work that we do and make ourselves more efficient by establishing the new WHO Health Emergencies program, which helps us work easily across the 3 levels of our institution, which is from the headquarters from here to all of our 6 regional offices, and then the more than 150 country offices that we have. And we also have changed the way we work, where we have a contingency fund for emergencies, so we don't have to wait to respond because of lack of funds. So we've seen in the past with the plague outbreak in Madagascar, the 2 Ebola outbreaks that happened last year, that we were able to move a lot more efficiently in supporting countries to respond to outbreaks. In addition to that, we also have there's unprecedented momentum, and part of this came after the Ebola outbreak, when countries were surprised and to a certain extent staggered by realizing that with a known, because we've been preparing for a novel virus or something to do with the pandemic, and we all came collectively, everyone came to understand that with known diseases hitting the capitals of cities, we could have a huge impact, not only on the fragile health system that already existed in the country, but also on global travel and trade. And it took a lot of us by surprise as we responded to that. So the positive thing that came out of this was the intergovernmental initiatives, the various development agencies that are now very focused on making sure that we're working not only to build response capacities, but sustainable capacities within all countries so that we can truly work as a global community. We've used, as I go to my next slide, we've used the review committee advice and recommendations that came out of post-Ebola to advise the work that we've done in moving forward. So for our part, we've tried to see how we could actually monitor and evaluate the capacities that countries had. For the past 10 years, countries have diligently reported through an annual questionnaire on the capacities that countries had. So the red box, I'm not sure if you can read the font, but the red box right on top talks about the annual reporting. So our states parties had insisted through Article 54, in a resolution under Article 54, that all states parties, in the spirit of mutual accountability and in the spirit of transparency, that all member states report at the World Health Assembly in May on how they're developing and maintaining their capacities of surveillance, response, and preparedness. So we'd been doing that for 10 years, but what we realized post-Ebola was, and the recommendation that came out, was that we didn't quite know the functionality of the capacities that countries said they had, especially for high-impact, low-probability events. So along with that mandatory part in red, we added 3 more functions, which was voluntary simulation exercises, voluntary joint external evaluations, and voluntary after-action reviews. And combining all the results that come out of this and the information that came out of this, we could actively update, review, and make sure that the national action plan to develop these capacities were relevant to the country and to the world. So I'll focus just briefly on the joint external evaluation because I'm sure most of you have heard of this. So this is work that we've done with our partners from various countries to develop a questionnaire that could be used in country. What's changed with the joint external evaluation is that it's not just a WHO team that goes in. It's led by WHO and our various partners at OIE, FAO, US CDC, the Robert Koch Institute. So there's various people that are experts from agencies and universities and ministries of health from around the world that are part of this external evaluation. And we look at 19 technical areas in the country, and we also have a field visit. All of these documents, including the reports, are online, and that's part of the that's done in the spirit of transparency and mutual accountability, where the countries that volunteer for this also volunteer to put the full report online. So what we're trying to do, as I showed you in the previous slide, was to be able to use the information that comes out of these reports to start the conversation between countries and partners, and also with different agencies in developing these capacities, and to see how we can not only have a 3-dimensional view of a country's capacities and the functionality of those capacities, but also to see how we can support them and to have the discussion go on. Around all of this, what I had mentioned earlier, but I'd like to mention now, is to make sure that what we've noticed in the past was, because WHO's natural partner is the Ministry of Health, the international health regulations always sat within the Ministry of Health. In some countries it sat outside, but in more than 90% of the countries it sat within the Ministry of Health. And as such, the international health regulations were always thought of in many countries as work that the Ministry of Health had to do. What this new process, the monitoring framework, and the way we're moving forward now has shown is that we want to engage, make sure that the international health regulations, as it was written, was a whole of government approach to preparedness and response, because the health sector sits across many ministries, not just the Ministry of Health. So a few of them, and the impacts of if anything goes wrong in a country also impacts various sectors. So we wanted to make sure that the various sectors, including agric, which is main, the transport and travel, security, and all of these sat within the health system that would be made more resilient with these sectors working together and having the information shared within the country, along with joint planning, joint response, and joint action. So just a quick update. This is not for anyone to read. It's we started this process in February of 2016. So specifically with just the joint external evaluations, we've had 72 countries volunteer. So as of today, this week we finished 2 JEs. We have about 56 of these reports online, and they are accessible to everyone. We're using these reports to update existing national plans, and for some countries we're supporting them to develop national plans, again with various partners. So that's my last slide. So thank you very much, and if you have any questions, I'll hand back to our chair lady.
Thank you very much, Raj. Because we are kind of running behind the schedule, I quickly switched to the last presentation, which is mine, and we will take few questions after my presentation, which is very short. I only have 10 slides, and I'm just happy to say that how do we close this? That we actually are now some 60 people participating, and about 50% of you are from REMPAN network. And the other half of participants are maybe not fully familiar what REMPAN is, so that's why I want just quickly to present what is actually this network for and about, and what is its role in supporting countries' efforts for preparedness and response to nuclear emergencies. So one may ask why WHO is actually dealing with radiation emergencies, whereas there is, of course, a specialized UN agency entirely focused on issues dedicated to nuclear safety, nuclear technology, radiation protection, and radiation emergencies. However, as Raj already mentioned, radiation emergencies, as well as all other health risk factors which may potentially represent health emergency, are under the scope of the international health regulations, which is a complementary additional legal tool which WHO is using as a framework. And the first one is international conventions for emergency notification and emergency assistance with the Secretariat at the IAEA. To both conventions, WHO is a full party, and in relation to that, WHO has certain mandate and certain responsibilities to make sure that we implement these responsibilities and support our member states' efforts to strengthen their preparedness and also assist them in response to radiation emergencies. Of course, WHO works closely with our external partners. These are UN agencies. These are our member states, health authorities of 196 countries. These are professional associations, non-governmental organizations, and our collaborating centers and collaborating institutions. And this is few words about emergency conventions. We will share the slides with you. You will have a link to download the full information about emergency conventions. So, of course, we work with our global expert networks, and one of them notably is Radiation Emergency Medical Preparedness and Assistance Network, REMPAN. It was put in place back in 1987. Last year, we celebrated the 30th anniversary of this network with more than 100 people attending this meeting in Geneva last year in July. Another important asset is also a global network of cytogenetic biodosimetry laboratories, which was launched 10 years ago, and the 5th coordination meeting of this network is taking place in June this month in Munich in Germany. So these are three key functions of REMPAN. So first of all, in actual emergencies, these network experts will provide technical support to WHO in responding to these type of emergencies. But most of the time, the majority of our efforts and time is spent on supporting countries in preparedness phase, in strengthening national and regional preparedness to radiation emergencies through providing technical tools, guidelines, support in policy development, Our REMPAN centers are providing regional and national trainings, workshops, and very closely involved in various levels of exercises. Notably, last year we had an interagency international nuclear emergency exercise held in Hungary, and our REMPAN centers were actively participating in this exercise. And the third function is implementation of IHR. Number of REMPAN experts are participating in joint evaluation missions mentioned by Raj, and also whenever the technical assistance is needed, we always rely on expertise of our network members. These are some examples of WHO radiation program and REMPAN activities aiming at strengthening preparedness in member states. This is development of guidelines, and notably the very recently published guideline on iodine thyroid blocking in case of nuclear emergencies was published in November 2017, and there's a link for downloading this document in PDF. We also contribute to relevant publications of IAEA, International Safety Standards, guides, requirements. Just a few days ago, there was a document published which was co-sponsored by WHO. It is a Generic Safety Guide 11, focusing on transition from emergency to existing situation, where WHO contributed with a component on public health and mental health impact. WHO also conducted last year a survey of national ITB, iodine thyroid blocking policies, and report is being currently prepared. Just to mention as a product placement, let's say advertisement, several upcoming events, what we're working on. Very soon is the JEE mission to Singapore, taking place on 16 to 20, not March, this is a typo, it's April 2018. It's the third Asian REMPAN workshop is hosted by our collaborating center, Kirans in Seoul in Korea, will take place 16-18 May, will focus on internal contamination, monitoring, assessment, and management. We have also the 5th BioDoseNet meeting happening in Munich in June, and several regional AirPAC congresses being co-sponsored by WHO. We are contributing to these congresses, specifically in emergency preparedness and response sessions. This is Asian Oceania Congress on Radiation Protection taking place in Melbourne in May, European AirPAC Congress in Hague in June, and AirPAC Cuba, which is Latin American Central American Congress taking place in Havana in Cuba in April. And we're also doing a long-term planning for the next Global AirPAC Congress in 2020 in Seoul, in connection with which we will hold as a satellite meeting our next REMPAN coordination meeting in 16th meeting in Seoul, Korea. So just a quick summary that WHO uses very important legal tools to as a framework for our activities to support countries in capacity building efforts for radiological and nuclear emergencies. And REMPAN is very important technical arm which supports these activities through development and implementation of relevant international safety standards, requirements, and guides, developing technical guidelines for health sector, providing opportunities for training, exercises, research, and development. And also network is an important platform for promoting and coordinating international cooperation in the EPR area through information sharing platform and through the network umbrella. With this, I will thank you, and we will see what kind of questions we have now. I actually copy-pasted them in the Word document. Two more in the chat window. Okay. How do I close this? I have to close this window. All right, just let me see. But it's still on the screen.
You need to plug the projector to this.
Yes. Clement, who was operating. I think I need to get the
Just say the.
You can read.
Just talk about.
Read the questions because that picture is nice. You can keep the picture and read the questions.
Okay, so the following questions were asked. First question is, would the slides be available after the webinar? Yes, we will provide the slides to those who registered and provided their true emails when registering. We will send the link for downloading the presentations, and also the webinar was video recorded, and the link to the video will be functional for about 1 month for those who would like to catch up and watch it later. The next question was to Dr. Kodama, and the question sounds like following. For the monitoring of long-term health effects, what is the recommended minimum radiation dose that should be considered? Yes, this is for him as well. I start over. For monitoring long-term health effects, this is for you. What is the recommended minimum radiation dose that should be considered or included in the registry, considering that the lowering the dose criterion will increase the registry population exponentially? So the question is, who should be subject to long-term follow-up for populations overexposed to ionized radiation?
Well, the question is, from what dose level we should include, people for a long-term follow-up study. My answer to that is we should include as many as possible, including lower dose exposed group, because we'd like to see those response in examining risk estimation. And for that, those who are exposed less amount and close to zero is quite important to do long-term follow-up. So my answer to this question is we should try to include as many as possible, even those who are exposed to very low dose level. That is my answer.
Thank you, Kaz. I think this is the opinion of epidemiologists, of the scientists, and I agree with you that for radiation epidemiology, it is extremely important to have as many as possible people. But I think the answer is not straightforward. There are also other issues, such as resources, such as ethical issues, such as overdiagnosis issues, which are now being actively discussed in the global expert community. And I think the answers to this type of questions should be answered rather sooner than later, considering all these factors, to develop some international criteria for people who should be included in the long-term follow-up and for the protocol of that follow-up. I think this is a very important question, was brought up by our colleagues from CDC. Thank you. Next question is also to Dr. Kodama. For a long time, it was considered that there is no clear evidence of statistically significant increase for exposures below 100 millisievert. You mentioned that you now see it in the range of 0 to 100 millisievert. Does this mean that you see statistically significant increase in risk at doses as low as 20 and 50 millisievert? Thank you.
My answer to your question is no. We try to detect increased risk by dividing dose range from like 0 to 50, 0 to 75, 0 to 100, something like that, and then we are able to detect increased risk when we analyze data using dose range of 0 to 100. This means risk elevation starts close to 100 milligrade. Doesn't mean risk can be observed lower than that. So please do not make any misunderstanding about this. Yeah. And there are those ranges very difficult to detect risks, but that doesn't mean there is no risk at all. So again, please be careful about interpreting results.
Thank you. Next question is to Dr. Whitcomb. It would be helpful to have some insight on how to practically manage the health impact of a detonation, recognizing that this would need to be done in the context of massive infrastructure damage associated with the detonation. Bob, are you still online?
Yes, I am. Yes, that's a very good question, and I did not go into greater detail regarding the medical management and public health management of exposed, contaminated, and those with severe blast and burn injuries. That could perhaps be a topic for another discussion later on as these webinars continue, or if we wanted to get further into the details in doing so. And I think from the talk prior to mine regarding Hiroshima and Nagasaki, the same type of altered standards of care, severe infrastructure damage, hospitals damage, staff also exposed and contaminated would also limit the resources that you could bring to bear in response to those. So there are considerations you can take in your planning. One thing we thought of in the U.S. is not, for the detonation, if it were to occur, to not consider it a local response. It would require a regional response over and across state lines in the U.S. if it happened here, to involve a regional response approach where medical, public health, first responders, and other experts can be brought in from the outlying areas to the impact. But yes, getting resources in will be hard, and getting victims out will be difficult. So it is a challenge, but not impossible.
Thank you, Dr. Whitcomb. You have one more question specifically to you. Do you have a special triage plan for nuclear detonation? If so, for example, where will it be performed and who will do it? Any documents guiding that?
There are a number of triage documents available, and I think, Jeanette, when you share my presentation, I would direct folks to several websites. For medical triage, I would direct them to the Radiation Emergency Medical Management website hosted by Health and Human Services. There are a number of concepts and frameworks. There's a couple of locations where people will be evaluated and triaged outside the blast zone, outside the contaminated zone. And in similar fashion, there are also public health resources that could be set up at community reception centers outside the blast zone and well outside the contaminated fallout zone. So the REM website is one I would direct the audience to, and then also REACTS is another one, the Radiation Emergency Assistance Center training site from the medical side. And then another medical resource we have in the U.S. is the Radiation Injury Treatment Network. And I think for many of the REMPAN members who were in participation in our meeting in Geneva in July, Cullen Case was there, and also Nick Daniak. So there was a couple of medical resources. For the public health resources, again, that would be CDC's website that includes triage concepts, not for medical, but more for evaluating and assessing contamination and exposure, and then directing those to medical resources from the public health side if needed. And that would be, the website is emergency.cdc.gov/radiation. That's where all of our tools, guidance, training, and public health resources are. And even if you go to our CDC website, we have links to both REACTS and the REM websites that I mentioned already. I hope that was helpful.
Yes, that I think answers the question. We also have a question was directed to you, but I think we can also answer that. In a nuclear accident, what are the exact criteria for continuing KI use for more than 24 hours release? And if the shelter facilities are not available, how effective are the partial decontamination measures? Well, for the continuous release, I can mention that WHO just recently published the guideline. I have it here with me, and I also mentioned it. I don't know if you can see me on the screen or not, because I think we're still in the slideshow mode. And I try to close it. Stop sharing. I have to find the button stop sharing screen. It should be there on the remote. Anyway, so in my presentation, I mentioned the new WHO guideline on use of potassium iodine in nuclear emergencies was published, and you will find recommendations for what to do if the release continues or repeated release. Whereas the question about decontamination versus sheltering, I think Bob is probably in a better position to answer it. If you don't have sheltering facility, how efficient would be decon against external iodine 131 contamination? I assume that was the question. Would you like to take that, Bob?
Yes, if there are no reception center facilities available and someone is sheltering at home, just removing the outer layer of clothing does remove a large portion of the external contamination. And if the water is still on and they are able to shower and shampoo and wash with mild soap and water, can remove even more. But then again, the sheltering in place is the primary protective action message that we have until it's safe to venture out to a location where they can get further evaluation.
Yes. Thank you very much. We have last two questions, and I'm afraid we have to run because the facility will be used for another meeting. The next question is to Dr. Raj Sreedharan. And the question was regarding JEE. Should a country necessarily request voluntary JEE, or should WHO, any of the three levels of WHO, request from the country to conduct JEE without member states' voluntary request?
No, so it's completely voluntary, the joint external evaluation. And part of this is to actually do the whole process of countries committing to sharing the information at the end of this. Countries can request specific assessments for just the laboratory or just for surveillance or something else. But if it's a joint external evaluation, it's a voluntary process. And once the country requests to the country or the regional office, then we support the country office and the regional office to do the self-assessment and then the joint external evaluation.
Thank you, Raj. And last question is, to me, apparently, how REMPAN can be better utilized in support of IHR implementation. What I wanted actually to mention after Raj's presentation as a comment, but it also answers this question in a way, that the follow-up of JEE, as you heard from the presentation of Raj, there is a putting together national action plans. And what we have not done yet systematically, looking at all JEE reports, taking out the radiation part recommendations, and trying to have some kind of a systematic approach to see for different regions what are the major gaps, what are the major needs, and in a more meaningful way deliver capacity building activities to REMPAN, by REMPAN institutions in meeting the needs, to meet the needs which were put in the JEE missions recommendations. So this is one very important component. And to analyze the reports, to have to look at all this data, if one of our collaborating centers would volunteer to help us with that work, we will very much welcome that. Thank you very much. I'm afraid we ran out of time. I want to thank everybody who took time to join us. We have participants from America to Japan, and even in our office in Pyongyang, colleagues connected, and China and Russia and Spain. Dr. Eduardo Gachego is there, and many of our friends and colleagues, and also new people. REMPAN is open for all specialist community. Please email us if you would like to know more about the network, about its activities, or would like to join the network. My email is Carr, C-A-R-R-Z, carrz@who.int. All the best. Thank you very much. Bye.
Bye.
Bye-bye.
Bye-bye.
Eduardo said,